a crucial area in our institute. And faculty, all the faculty, like in a room sat and they decided that we really don't know much about research, हमको नहीं आता है, and we need to improve. So understanding or pointing out the problem becomes very important. And of course, everyone is not sure what to do. So there was this issue or barrier towards doing research. So CRS was created to kind of ensure that research is done properly. So the roles of CRS that was given to it was help people conduct research, try and build collaborations, do capacity building. So basically do research workshops for faculty, okay, do writing workshops for how to write a paper, how to do research, and so on and so forth. Conduct national and international workshops and manage data for large projects and so on. And also manage pharma trials. So this was kind of the roles that were assigned to CRS. We talked about one of the answers of collaboration. So we had, in 2010, we began working with some medical institutions in the US. And this is a picture which shows people from US visiting our institute and having collaboration. So we had a collaboration 2013 onwards. So this is in my house. Some of the collaborators are there. The kids were very small at that point of time. So not only did they come to our place, they invited us to US. Here I'm delivering a lecture at Boston University, on a Boston University India Symposium. So collaborations become very important. So what I mentioned there kind of helped. So again, visiting the collaborators in the US. So you can see here, this guy is an MBBS student. So generally when I travel, I would usually take students with me. These are the students from UMass who came to India to kind of work with us. Subsequently, this again here there are students. This is again a DCH student of ours who is now in the US. And this is a MBBS student of ours who was presenting there, who traveled with us. Okay. So we had scientific writing workshops, okay, which were being conducted. So in 2009, we said it was started. In 2010, I took over CRS as head of the Central Research Services. And in 2013, we decided that we'll work more with undergraduates. And this became significant turning point in our place because generally we look at PGs, etc. But also teach postgraduates, but focus also on undergraduates. So normally most colleges don't look at undergraduates as doing research. Okay. And I'll come to the slides which show how it turned out. So we were also doing our own research, and we did a silicosis study, and this is not me, but other collaborators in CRS who did a study on silicosis, and which was published, and note of it was taken by the National Human Rights Commission, which directed the state government to do something. So the point is, if you do research and you publish it, it helps attention of policy change to happen. So policy in the Gujarat government changed because of these few papers on silicosis that were published from our institute. We got ICMR grants over a period of time. And we also did a few other studies. And what happened post 2012, after 3-4 years of starting CRS, is post PGs started publishing regularly. पहले publications PGs नहीं करते थे, उसके बाद publication चालू हो गया, and undergraduates started publishing since 2014. So what CRS basically does is it's a unit of 3-4 statisticians and 5 statisticians at various points of time, and we ensure that we do research workshops. जो BCBR का आया है MBBS में अभी for MD students, it has come recent in the last 3 years. But we started doing this teaching of PGs and UGs in 2010 onwards, where research methodology is taught to PGs, faculty members, as well as undergraduate students. Before the PGs submit their proposal to the ethics committee, it is gone over by the statisticians, and the research design is discussed in detail. And they come back to the CRS on a regular basis to see if things are happening correctly, if the Excel sheet has been filled correctly or not. Any things are missing. And even before thesis submission, again the analysis is held by the statisticians of CRS. And recently, in the last 3 years, all the PGs are made to submit a manuscript before thesis is kind of signed. So thesis is not approved till the manuscript is submitted. And of course, we also help for submission of grants. This is one research group which we had. So the group which directs the CRS, kind of the body which kind of looks at what CRS should do, is constitutes of students and various other faculty members. So it's not just pediatrics, other faculty members also are there. So few stories and pictures. I talked about these two individuals from students from US who came to work with us, and they have been working with us for almost now 13 years. These are my statisticians, Mr. Ajay and Ms. Jayashree. And we started working in 2009, 2010 I took over. It took some time for efforts to kind of be useful. So in 2011 we submitted to the Pediatric Academic Society's conference in US, and we got 9 accepted abstracts, which is a huge number for PS. Mostly people get 3-4 abstracts accepted. So one oral paper was on simulation and 8 posters. Just before this in 2012, you can see this person, Vivek Shukla. He was a PG and he won the James Slate Award for us in 2012. Okay, and in 2012 again we submitted papers to another EAPS. So these are 5 of us went. The 5th person is Dr. Satvik Bansal, who is now an assistant professor in Gwalior. He is not in the picture. So this is again an MBBS student. He was an intern at that point of time. This girl was a second MBBS student. So they all came. He was a fellow, neonatal fellow. They all presented papers at that point of time. We had one oral paper. This one got a oral first prize in the EIP conference. This, I don't know whether you can see, but this is our third MBBS girl presenting a paper on nursing burnout. So this paper got published later in Indian Journal of Pediatrics, and study over a wide number of colleges that happened in North India and got published in Journal of Neonatology recently. So these are again MBBS students presenting abroad. This is Dr. Shikha. She got award from the Minister Ghulam Nabi Azad in 2014 January at a conference for her paper on neonatal pain. So again, this is a picture taken before traveling to Vancouver in 2014. Mr. Ajay, Dr. Ami, Dr. Arshil, Dr. Divyanshi, and Dr. Shikha, who traveled with us to Vancouver to present papers. At this particular paper, I think we had 14 abstracts. These are some pictures from the conference. These are all MBBS students mainly. Collaboration, so you kind of make collaborations with others. So here met new people, Nitin Chotai, who's working with us on some research projects, and Martin Glocko, who's a well-known name in neonatal echocardiography. So this is a picture taken at Vancouver. This is Dr. Vivek Shukla, who then later on went to do fellowship in Sick Kids and now is a professor in Birmingham, Alabama. This is a fellow MBBS students, and Harshil. Harshil now is a cardiologist in US. So this Dr. Rohit Vasa is the person who kind of pushed me towards submitting papers to pass. He with MBBS student and my professor of neonatology, my second in command at our college in 2014. So for one of the papers that I showed, we got selected. We did not win the award, but we were the finalists, one of the 3 finalists at BMJ Awards. This is the student presenting in the next conference in Dubai on kangaroo care. So what happens is you get a lot of collaborations. Students from India go to our other institution there in the US. Students from US come over here, and there is many of these students end up doing projects. So my thing is, if undergraduate students of US can do research projects, why can't our Indian students do? And we have tried and shown that it can be done. We also have some clinical, tribal work that we do in Dahod area. We got ICMR awards, roughly around 1.5 crore projects for this particular area. We celebrate achievements of undergraduate students. So these are all mostly undergraduate students. When post-publication in PubMed Index journals, we had a party. So selfies. So these are all smiling faces. All of them who have become doctors now. In 2016 in EAPS, we had 27 papers, 19 abstracts, 8 oral papers. 13 undergraduates either presented orally or did a poster presentation. 1 PG, 3 faculty members, 2 fellows, and 3 couldn't come because of various reasons. So this is a picture at that place. There's another student of us presenting in EAPS. So when you go with students, it's a lot of fun time that you can have. And so this is one picture at Lucerne. I don't know if you have been to this wooden bridge. Okay, so again, similar faces. This is me at that point of time, and so so unless you move with people, interact with them, so there is confidence building that happens with the team. Then you can have more work done. So this is picture with all the people who couldn't go. Many of them couldn't go or did not want to go. Again, subsequent PS. Again, these are UG students. So the process, as we say, is you saw a lot of undergraduate students presenting in 2016. So they did not suddenly do this in 1 year. In the first MBBS in 2014 or so, they had a 2 months training over a period of 2 months training in physiology on how to do research. So first MBBS students got training in research in first, and they got interested, and some of them went and did pediatric projects. I'm talking only of people who have done pediatric projects. There are people who have done medicine and obstetric projects too. Many of them end up doing publications, at least 2 to 3. One girl has completed 10 publications by the time she finished, and these are all 10 PubMed papers, not in any journal, all good journals that they have published by the time she finished internship. And the amount of work that they can do can vary from just collection of data to writing fairly good papers, and it is a process of learning over a period of time. And at times you can have people who are interested at first and then kind of give up. Now, why this became very specific is because out of the papers that I am part of, almost 30% of the papers are from undergraduate students. It's not that PG students, it's undergraduate students who had no reason to do research, but they decided that they wanted to do. So undergraduates, the advantage of doing research as an undergraduate is there is no boss to report to. If the guide is not interested, then the PG, even if he's interested, can't do anything. Okay, there's no clinical pressure, and you can start off early and you can do a lot of good work over a period of 5 years. Okay, so it's much more easier that way. But the topics kind of can become restricted. So as I said, initially in 2009, we had this interest in research, and the management decided to pursue it. So we had a board of management, and you can see that these are well-known names across India in research who kind of help us formulate policies. So these are various policies that are formulated for travel support, for doing research, getting funding for research from within the college itself, and what can be done and what cannot be done. So these are various other current members which are there. Okay, all of them have published quite a lot of extent. So if you can see, the last name is Director of Gujarat Biotechnology Research Center. So he is kind of one of the best centers on biotechnology in Gandhinagar he heads. So what I want to say is, if you are able to give good mentorship and guidance, and if you are able to follow a process, everybody who is interested in research can become an excellent team member. Very important to do team building and faith. So you cannot just have an professional engagement, you have to have interaction at a personal level too, and of course be very open about limitations. Okay, we need to avoid very complicated topics, and very simple topics also can have excellent results. So in general, in short, this would be my experience per se over the period of last maybe 15 years or so since starting research in a very good capacity. So this is what I have ended up with as of now. So when we started, even in our college, a lot of people told us that this is not good. Kaun karega ye? Time milega kya? But we ended up doing much better and publishing a large number of papers in the last few years itself. So and this is a very interesting story. This girl is a 11th standard girl from New Delhi. This is not a medical student. We collaborated with her. She did work on artificial intelligence. And this girl, who was 17-year-old, she presented in 2021 and 2022, and she won this EAP Young Investigator Award. So she's not even a medical college student. So the point what I'm trying to make is, anyone who's interested and who is willing to devote time to work towards research can achieve excellent results. So these are again few students. So I was not interested in applying for the award, but Binoy said, then sir, we should apply. I said, okay, I'm not going to go. So then he applied. He couldn't go, but this girl went and presented, and we won. So I'd like to acknowledge a lot of people who have led this. So one is on the left hand, Mr. Sandeep Desai, our CEO, who kind of began this focus on research. Dr. Amrita Patel, who was our previous chairman, who kind of ensured that funding was available, and Dr. Pandya, who is our current dean, who has also been part of this journey. Various mentors who have helped me get through various places and helped me with a lot of work in the last few years. This is our current Department of Neonatology, with me in the center, flanked by my two faculty members, Dr. Deepen and Dr. Reshma, and the rest of them are DM students. So we split from the Department of Pediatrics in 2019, And so, but we still work closely with them. So this is the Department of Pediatrics with MD students. Okay, this is our Central Research Services team in the bottom frame, and there are a few of them with collaborators. So I worked with a lot of people. I said 150 plus collaborators. I just put a pic of some of them who have worked with, and they kind of send the pics in time. So you can see that they're all young people, MBBS or just past MD. I'd like to thank my family members, my wife and kids, who have helped me and and allowed me to do a lot of this work. So in summary, it's possible to go from zero to hero. Okay, it's not, so as I said, I was never trained, and we decided to focus on it, and everything is kind of self-learned and with interaction and collaborations. Okay, so there is something called as self-directed learning in the new curriculum for MBBS, but it applies to faculty also. So unless we start learning on your own, we are not able to do much more. Very important to have leadership support. So unless you have management support or your dean supports, it is very difficult to do if you don't have all that. So that is something which I acknowledge and understand that if you don't get it, it might be difficult. And you will get anything that you want to do if there is passion and you're willing to back it up with hard work. Most important is you cannot achieve anything alone. Okay, for doing anything, a team is vital. Without the team, you cannot achieve anything. And the ultimate achievement of leadership is creating more and better leaders. I would like to thank everyone for patient listening, and I hope I have done some justice to the topic. Thank you very much.
Thank you, Professor Nimbalkar, for talking on such a relevant issue. It is really very relevant. I remember long back, there was a slogan, publish or perish. Publish karo nahi to baad mein jao. I think that is true even today. And there are some changes also, like previously whoever was the authors, the team of authors, everybody received the same credit. Later on they said that first author will get more credit than the co-authors and no credit to gifted author. So these are the something, and yes, true that we should increase our publication. It is very, very true. And this, your lecture, your presentation must be a lesson to all the PG students and all the young doctors, young pediatricians.
Respected Dr. Nimbalkar, very nice presentation. So we are very much pleased with you. Okay, thank you.
Thank you, sir.
Thank you so much to our orator, and thank you so much to the chairpersons. I request all the three of you to please collect your mementos over there from the rear side of this. Okay, we have mementos on the stage. And thank you so much, everyone, for your kind and patient listening. And let's now move to our next topic. Let's cover a new topic, which is acellular pertussis versus whole cell pertussis. And to chair this session, I'd like to invite Dr. Ankur Priyadarshi, currently working as Assistant Professor, Department of Pediatrics, GLNMCH, Bhagalpur, since 2015. And also I'd like to request Dr. Rupesh Kumar Thakur, who is MBBS and MD in Pediatrics, both from DMCH Darbhanga. He has worked for 1 year as Assistant Professor, Department of Pediatrics at KMCH Katihar. And also I'd like to request Dr. Ruchi Jha, who is Assistant Professor, Pediatrics, MGM Medical College, Jamshedpur. So the next topic we are going to cover, Hexacil, and the keynote speaker on this topic is Dr. Avadh Agrawal. So I'd like to request Dr. Avadh Agrawal to kindly be on the stage and to present his presentation in front of you all. And now I'd like to request all the chairpersons to please give us a brief briefing about Dr. Avad Agrawal. Thank you so much, and over to all of you. Over to sir.
Good afternoon, everyone. And it's my honor to introduce a personality like Dr. Abhadar Agrawal sir. And he's going to talk about the next session that is on the pertussis vaccine. And sir needs no introduction. Everyone knows about him. Dr. Agrawal sir is an associate professor in State Institute of Health and Family Welfare, and he remains trainer for the various health programs. He has more than 100 talks on the national level of PEDICONs, as well as he was a panelist. Hello. So good afternoon, everyone. And the next session is on hexavalent vaccine, particularly the pertussis vaccine. And the talk is on acellular pertussis versus wholesale pertussis vaccine. And our speaker for this session is Dr. Avad Agrawal sir. And it's my honor to introduce the persons like Dr. Avad Agrawal sir. He needs no introduction. current Sir is Associate Professor, Pediatrics in State Institute of Health and Family Welfare, Patna. Currently, he is giving the training and is a coordinator of various health programs. Sir has more than 100 talks in the national level, is joined state PEDICONs in Bihar, Jharkhand, and various routine IAP meetings. So without wasting any time, I would like to request Dr. Abad sir to kindly start his talk. Thank you, sir.
Thank you, Chairpersons. A very good afternoon to all of you. And first of all, I'd like to thank Darbhanga IAP and the PEDICON organizers for giving me this opportunity to interact with you. The topic that I'll be discussing today is the hexavalent vaccine and the controversy that still lingers between the acellular and the wholesale pertussis vaccines. You all know that this topic was a very highly debated topic, so high that it created a big storm in many conferences, and people, they even resorted to fisticuffs. There were two schools of thought. One school was claiming that the wholesale pertussis is definitely the best vaccine in comparison to the acellular vaccine. And the other school was telling, no, this is equally good. So much so that even the central IIP and the IIP COV, that even got confused, and it came with the recommendation that for the primary series, we should give the wholesale pertussis vaccine. Then again, the controversy brewed, and the recommendations were changed that you can go either of the way. You can do the priming either with the wholesale or with the acellular. So let us discuss what the science says and what the latest publications throughout the world and what the latest studies they are telling you regarding this controversy, so that the picture will become a bit more clearer when we discuss these issues. Now, the background of the talk is that definitely vaccines reduce morbidity and mortality. This we all are agreed upon it, that vaccination is the best cost-effective intervention among all the various health programs. Now, the high vaccination coverage rates is crucial to prevent diseases and outbreaks. So whenever you are running a vaccination program, the aim should be to increase more and more coverage to take it nearly to 100%. Then only you can get the results of the vaccine. Because if the number of recipients are less, then the desired level of coverage and the herd immunity will not be achieved. So our aim should be to go for more and more coverage of the vaccines. Now, vaccination is nowadays becoming a challenge. Why? Because newer vaccines are added over a period of time. So there was a time when in 1978 only very few vaccines, when the UPI was launched or the EPI was launched, very few vaccines were there. But nowadays, we are having more and more, and it becomes a Herculean effort to give all the vaccines with the minimum number of effort and minimum number of sessions. So increased number of injections administered in a single visit, leading to refusal of one or more immunization due to fear of needles, pain, and unsubstantiated safety reasons. Now, the science of vaccinology says that you can inoculate any number of vaccines at a given time. There's no limit to it. It is said that our body is capable of handling even 1,000 antigens at a time. But the point is that except for the OPV and the Rota, all are in the injectable form. So how many pricks can you give to a child in a single session? So that becomes a challenge. Now the newer vaccines which are available, they increase the complexity of pediatric immunization schedules, and so the schedule has to be retailored, and it leads to significant reduction in vaccination coverage. So there is a great need to simplify the administration of the existing vaccines. So comes the age of combination vaccine. The combination vaccine is also not new. We were having, say, the DPT since very, very long time. We were having MMR since very, very long time. But in the last decade or so, we are having, say, pentavalent vaccines, hexavalent vaccines. So all these combination vaccines are coming, and more research is being done to include more and more antigens in a single sample. So this will definitely go a long way in incorporating more and more antigens in a single prick. So the combination vaccines, how does it help? In children, it improves compliance and timeliness. It reduces pain and discomfort due to fewer injections. For the parents, it is better acceptance, high willingness to pay to avoid extra injections, and it saves time and reduces number of visits and days lost. Now the doctors, it is also for the doctors also, it is time saving, it reduces administration tasks, simplification of cold chain storage. You have to, nowadays even the doctors who are having, they have to increase their cold chain storage capacity because more and more vaccines are there and they're all coming in single pack and big packs. So, and for the doctors, it also increases safety for healthcare staff due to reduced needle stick injuries. So you see, the combination vaccines are helpful for all, for the children, for the parents, and for the doctors. Now come to the Indian DTP vaccination scenario. What is the present picture of the DTP vaccine in India? So 3/4 children aged 12 to 23 months in India are fully vaccinated. By fully vaccinated, we mean by that they have received all the vaccines that is there in the NIP. So 3/4 means nearly 75%. So 25% of the children in this particular age group are still not fully vaccinated. Now more than 3 million children did not receive any routine vaccination in 2021. So 3 million, that is nearly 30 lakh children, they have not received any of the vaccines. Now, India is a big country, the most populous country in the world with 140 million population, 140 billion population. So this may not appear to be a very big figure, but still, this is a large figure and we need to improve upon it. So making India the country with the highest number of children with zero dose status worldwide. Of course, we have the largest population. Now, if you look at the DTP containing vaccine, in 2021, let's take the latest figure. We have figures of 2019, 20, and 21. In 2021, the DTP containing vaccine first dose was covered by 88% of the Indian population, the children population. And the DTP containing third dose was 83.5%. That means that there is a drop rate of 5%. So 88% of the children received the first dose and only 83% received the third dose. So a drop rate of 5% is there and this has to be looked into. Now these are the 6 serious diseases that is covered by the vaccine. We have the hexavalent vaccine. You all know about it. We did not go into the detail. The diphtheria, tetanus, pertussis, hepatitis B, Hib, and the 3 varieties of polio, that is the type 1, type 2, and type 3. Now, what are the prerequisites of a hexavalent vaccine in India? What should be the prerequisite? Now, regarding the polio component, the OPV is essential for eradication of polio, but carries a rare risk of vaccine-associated paralytic polio and circulating vaccine-derived polio virus. Now, the OPV, why it is being discouraged or it has become nearly obsolete in most of the European countries and US, because it had 2 important side effects, that is the VAP and the CDPV. So we all know about it. Now the OPV cessation and IPV introduction, this is our goal. That is why if you look at the IP schedule, we are giving oral polio only at birth, and the rest whenever we are giving at the 6, 10, 14, 18 months, 5 years, and there is no recommendation also coming up that at 10 years also we should give an injectable polio. And OPV, we should forget about it. Only when there is a drive, say the pulse polio drive, then only the oral polio should be given. It is essential to continue polio-free status of our nation because there are still many countries in the world which are having wild polio and many more countries which are having VDPV and VAP. Now regarding the pertussis component, it should have an acceptable safety profile of the wholesale pentavalent vaccine, wholesale pertussis pentavalent vaccine. So if you are having a whole combination vaccine with the wholesale pertussis, it should have an acceptable safety profile. Now we all know that the efficacy of the wholesale pertussis was superior versus acellular pertussis, but it also had slightly higher adverse drug reactions with wholesale pertussis. Now the wholesale pertussis offers long-lasting protection as protection with acellular pertussis wanes rapidly. So this is the correlate of protection of all components. You need not memorize all these things. This is the minimum level, this is the optimum antibody level that should be achieved for giving protection against all the diseases, that is the anti-diphtheria, tetanus, pertussis, hepatitis B, and the polio type 1, 2, and 3. Now, how do we define the correlate of protection of all components? If you look at the pertussis, in subjects with no quantifiable antibody, that is below lower limit of quantification, that is LLOQ, that is the lower limit of quantification, prior to vaccination, if the person is seroconverted, that is then the seroconversion itself is defined as achieving a quantifiable antibody level post-vaccination. So this is how you go about testing. And in subjects with quantifiable antibody prior to vaccination, the seroconversion is defined by a 4-fold increase in antibody titer from pre to post vaccination. So if you are giving the pertussis vaccine, how do you judge the efficacy? If there is a 4-fold increase in the level of antibody titer, then we define that the vaccine is working. And the level of anti-B pertussis should be 24 IU per ml. So what is the basic difference between the wholesale and the acellular hexavalent vaccine? The major difference between the hexavalent vaccine is that they either contain a wholesale component or 2 or 3 acellular pertussis components. Now we all know that basically there are 5 antigenic components in the acellular vaccine. That is the pertussis toxin, which is the basic component and it is contained in all of them. Then the filamentous hemagglutinin, pertactin, and fimbrial antigens type 2 and 3. So if you look at the GSK series, that is the Infenrix, series, that is the, they have the hexazim, then they have the pentaxim, then they have the tetraxim, that is the Sanofi series. So they contain 2 antigens. And the GSK people who are having the Infenrix hexa, they contain the 3 antigen. And except for the Adacel, which is there in the Sanofi, that contains 5 antigens. So most of these acellular pertussis vaccine, they contain either 2 component or 3 component, and only one of the brands is containing the 5 component. Now come to the facts that is happening around the world, that is the recent outbreaks of pertussis. Now the outbreaks of pertussis are regularly reported from many countries like USA, UK, Australia, Chile, Brazil, Colombia, Pakistan, etc., despite having high vaccination coverage. So there are many countries which are having high vaccination coverage, but still they are having, epidemic outbreaks on and off. So this, what are the factors behind this resurgence of pertussis? This is mainly due to waning of protective immunity and shorter duration of protection and probably lower impact of acellular vaccines on infection and transmission. Now, at least 5 trials they have found that whole cell pertussis vaccines had greater efficacy than the acellular pertussis vaccines. Now these trials, this was published in the Indian Pediatrics 2013. Then many later trials have also hinted that the efficacy of the acellular pertussis vaccine may not be as robust as reported in the initial studies. This again was published in the Clinical Infectious Disease Journal. The details are given. Now recent data from US and Australia, they have suggested that reduced durability of vaccine-induced immunity after the acellular pertussis vaccination in comparison to whole cell pertussis vaccine. So these findings suggest that priming with whole cell pertussis is more effective at sustained prevention of pertussis disease rather than acellular pertussis vaccine. So this publication suggests that the priming series, at least, if you do it with the whole cell pertussis, it is definitely better than the acellular pertussis. Again, Ravid and colleagues, after reviewing data from the Kaiser Permanente, North California, they have also concluded that a wholly acellular pertussis vaccine series was significantly less effective and durable than one that contains at least one dose of the traditional whole cell vaccine. So even if somebody is giving the whole series with the acellular, if at least one dose of whole cell pertussis vaccine is given, then that changes the whole immunity profile of that child. Even the IAP Guidebook on Immunization 2018-19, they have also said that the current evidence is tilted in favor of whole cell pertussis vaccine as far as effectiveness of the pertussis vaccines is concerned. Now, what is the difference in the immune response between the whole cell and the acellular pertussis vaccines? Now, the whole cell vaccine, if you look at the T cell response, the T cell response is that of Th1 T17 profile with functional tissue resident memory T cells in lungs and nasopharynx. So the T cell response with the whole cell is that of Th1 and Th17, and this leads to the formation of tissue resident memory cells, which are very, very needed in the locally in the trachea and in the nasopharynx and in the lungs, which fights the Bordetella pertussis bacteria. Now, what is the B cell response? There the opsonizing and neutralizing IgG antibodies are formed. So the protection against the disease, short term, yes, and long term protection up to 10 years. So it is now beyond doubt established that the whole cell pertussis vaccines, they give you protection nearly up till 10 years. Bacterial clearance, rapid and high level clearance of pathogen from nasopharynx and lungs. Transmission, low risk. If you look at the acellular vaccine, the response is that of Th2 and Th17 type of response, whereas Th2 is redundant for protection. Low levels of opsonizing IgG antibodies and neutralizing antibodies. Short-term protection, yes, it is there, but long-term protection, the immunity wanes after 3 to 5 years. And there is failure to clear the Bordetella pertussis from the nasopharynx, so the person remains carrier for a very, very long time, and there is a high risk of transmission. So this is the comparative analysis of the two vaccines. Now, if you look at this chart, you'll find that there are two scenarios. One, in which the priming has been done by the whole cell pertussis and the boosting is also by the whole cell pertussis. Then you have the green part. If you're looking at the green part, you'll find that it has stronger and faster effects of the booster on either T or B cell response. So if in the T cell response, you'll find that interleukin 17 formation is there, and TRM, that is the tissue resident memory T cell boosting, is also there. And among the B cell response, you'll find that there is a potent generation of plasma cells, germinal cells, and memory B cells. And there is evidence of retained B cells in the lungs, and there is broader diversity of antibodies. So this happens with the whole cell priming, and the boosting Whether it is done with wholesale or acellular, the effect is the green. In contrast to that, if you find this is the second scenario in which the priming has been done with the acellular pertussis and the boosting is there with the wholesale pertussis. There you find the green is only there with the B cell response. That is, if the B cell response will be there, but if the acellular pertussis is there for priming and also for the boosting, then you'll find that you have the red response. What is the red response? There is interleukin 4, which is weak in comparison to interleukin 17, no TRM cell formation, and no 7 T cell boosting. And there you have weaker induction of plasma cells and germinal cells and memory B cells. So this is the comparative analysis, the scientific data behind which how the acellular and the wholesale pertussis differ in their actions. So the T cell response, a large body of evidence shows that there are significant differences in the immunity induced by the two different types of vaccines currently in use, that is the wholesale and acellular. The main difference consisting is that of the Th2 response from the acellular and Th1 and 17 response from the wholesale. The immune response resulted after wholesale pertussis vaccination mimics the immune response after natural infection. That is, natural infection with wholesale pertussis induces Th1 and Th17 dominated response. And according to published reports, the immunity induced by acellular pertussis vaccine wanes more rapidly than those with the wholesale, and it does not induce durable immune response. Now the T cell response, WP, that is the wholesale, it results in the formation of specific tissue-resident memory cells. It also induces IL-17, which is necessary for the clearance, bacterial clearance, and the IL-17 results in clearance of body-tailor pertussis. And the TRM cells play a critical role in maintaining long-term protective antibody. It significantly reduces the body-tailor pertussis loads, and it provides protection against colonization and reinfection, thereby prevents transmission. So the herd immunity is also much, much better if you are immunizing the child with the wholesale. Now the wholesale component contains vaccines. They are efficient in providing herd immunity, whereas the AP containing vaccine failed to offer herd immunity. And in contrast, immunization with AP containing, it gives you only protection from the symptoms of the disease, while it is unable to shorten the body-tailor pertussis dwell times within the nasopharynx, and it does not prevent transmission to the non-infected, that is no herd immunity, and it is insufficient for inducing local response to infection and counteracting the persistent burden of body-tailor pertussis within the upper respiratory tract. So to summarize the whole two, the wholesale induces Th1 for this formation of TRM cells, it secretes interleukin 17A, it clears body-tailor pertussis from the nasopharynx, and there is production of opsonizing antibodies, IgG1. Whereas in contrast, all the 5 things, all the 5 points that I have mentioned is not there with the acellular pertussis vaccines. So IgG are superior to Ig4 in terms of pertussis clearance, and this IgG1 is formed by the wholesale, and the acellular produces Ig4. This again is the plasma cell response. So how do we prime? At least one, ideally first, wholesale pertussis vaccination offers better protection against pertussis versus a schedule that only consists of acellular pertussis, and duration of immune protection with acellular is insufficient regardless of the schedule and number of doses, and increasing number of acellular boosters, short lasting and rapidly waning protection. The priming leads to faster and stronger stimulation of memory B cell and leads to induction of antibodies with a broader antigenic and isotypic diversity, that is nearly more than 3,000 antigens. Demerits of using acellular, it is shorter lasting immunity, insufficient protection, increasing incidence of pertussis in older children, and there is a progressive rise in the number of cases for more than 20 years in Europe as well as other regions of the world. Now, these are some of the published literature which shows that the adult population in Greece, they are having lot of pertussis carriers. Again, these are all the scientific evidences, that is the long-term protection offered by WP vaccination. Again, these are various publications. We don't have much time to go into the details of it. These are the trials that was conducted. Now, this new vaccine that has been launched, that is the Hexacil by the Serum, they have an Indian trial, whereas we have 4 options right now. One is the AZ6, then Hexacil, Infanrix Hexa, and the Hexacil. The Hexacil is the only vaccine in which the booster trial has been done in India, whereas the other vaccine, either the booster trial has not been done or the trial has been done outside India. The newly introduced hexavalent vaccine by the Serum Institute, you all know the details about it. This is the trial that they have conducted, the Indian trial. That is, they have taken nearly 18 sites. These are the 18 sites where the trial was conducted, and the results are here shown graphically. That is, the vaccine has to show that it is non-inferior to the already existing vaccine. So the red bars are the Pentavac and Poliovac combination, and the Hexacil is the new vaccine. And you look at if you look at the graph, you will find that both the graphs are nearly parallel. That is, it is showing that it is non-inferior for all the antigens. Then again in toddlers, I'll just show you the last slide, just the last slide. Yeah. So no vaccine related adverse events. So the take home message, just the take home message, that is the most affordable indigenously developed vaccine, and there all the things there, the positive that has already been discussed. And now the topic, it is up to you that you consider all these scientific evidences. Thank you.
Hello, and thank you very much, sir. You have nicely explained the all dots which are prevailing in practicing medicine regarding wholesale and acellular vaccine, and it will be very helpful for we practicing pediatrician and all guardians too. Thank you, sir.
Thank you, sir. You have explained the topic in great detail, starting from priming, efficacy, effectiveness, generation of memory cells, and covered the topic excellently, and will have left no doubt in any of the physician's mind regarding the difference between acellular pertussis and wholesale pertussis vaccine. Thank you, sir.
Thank you, everybody. And let's go to the rear part of this hall for taking memento. Thank you very much. There is a small announcement that there will be no recess for the lunch. The scientific session will continue, and I wish that everyone will enjoy scientific session more than the lunch. Thank you very much.
Thank you so much, sir. And the next topic that we are going to cover now is neonatal shock. And to chair the sessions, I would like to invite all the chairpersons on the stage. Dr. Amit Nayak, who is the Assistant Professor at Darbhanga Medical College. Then Dr. Vibhas Ranjan, who is Assistant Professor at Department of Pediatrics, DMCH. Dr. Shahnawaz H. Varsi, he is ex-SR Department of Pediatrics, DMCH Darbhanga, and now he is working as SMO SDH at Jayanagar, Madhubani. So the next topic that we are going to cover now is neonatal shock. And to present the presentation, our keynote speaker would be invited, Dr. Shravan Kumar. So we have with us Dr. Shravan Kumar, and now I'll be requesting one of the chairpersons to please give us an introduction about Dr. Shravan Kumar. Thank you so much.
Dr. Shravan Kumar has done MD, DCH, and fellowship in the NNF Neonatology and president in NNF Bihar. He is the national trainer in NRC and FBNC. Still-wise, he is the first NICU in the Bihar, and that is popularly called is the father of neonatology in Bihar. Keep in the spirit of low-cost NICU and the Bihar with the kangaroo care. He has their own YouTube channels, named as the NBCC Patna of the Dr. Shravan Kumar, with the more than 30 videos, important disease of the children is uploading. All the videos are very popular and they are more than 1,000 subscribed and more than lakhs of the views in the channel. He is educated at the general mass with the usual tip of the care of the newborn, so all the child is protected with the fatal disease, and he should be intact survival with the all in development. He is a very active in social service and awarded in NNF fellowship in national well. I request all of you to please hand together with he is elected as the IAP Bihar President 2024.
Congratulations, sir. Dr. Shravan Kumar needs no introduction in Bihar. He is the first stalwarts of neonatology in the Bihar. And I think he is the first and almost of its kind established his nursery in the Patna. And I think he have successfully discharged more than 1 lakh of newborn. Sir, congratulations to you for being elected as a president and president IAP Bihar. Thank you, sir.
Thank you. First of all, big thanks to all the members of Bihar for electing me as a president. And it is a very prime privilege that I am also a student of this institute, Darbhanga Medical College. And I am very much enthusiastic that I will need your help to make IAP up to a great height. And it will be done, sir, it will be done. And neonatology is very important in pediatrics. In pediatrics, everybody needs neonatology. So this is the base of pediatrics. And I have chosen the very important topics. Neonatal shock. The neonatal shock is a very important in neonatology, and every diseases terminate in this condition in last stage. So you have to know how to treat this neonatal shock. And what is shock? Shock is a state of cellular energy failure resulting from an inability of the tissue oxygen delivery to satisfy oxygen demand. I mean to say that this not only circulatory failure, not only of a blood pressure is important. It is the oxygen demand, whether the oxygen is fulfilling the oxygen demand of the tissue. If that is fulfilled, you should not bother about the blood pressure. And the shock is due to circulatory failure, maybe due to the decreased oxygen content in the blood due to hemoglobin, or maybe due to any cause, but the main brunt is the cellular demand, cellular demand of oxygen. And what is that principle of oxygen delivery is the product of cardiac failure, cardiac output, and arterial oxygen content, whereas the cardiac output is a product of heart rate and stroke volume. That means that how much blood is pumped out in 1 minute, that is cardiac output. And the key determinant in the cardiovascular performance are 3 things: preload, afterload, and contractility. preload means that the pressure before heart, that in inferior vena cava, and after load, the pressure after heart in systemic circulation. And contractility means the heart itself, how it is working. So these three things very important in cardiovascular performance. And the pathogenesis of neonatal shock, the etiological factor are only three. Hypovolemia, myocardial dysfunction, abnormal peripheral vasoregulations, and hypovolemia. The hypovolemia may be absolute, intrapartum, intrauterine, and postpartum. So whatever the cause of hemorrhage or blood loss, that may cause hypovolemia. Relative, increased venocapacitance. If there is venodilatation, the relative hypovolemia. In combined septic shock, both this venodilatation and blood loss, hemorrhage may be there. And hypovolemia, in hypovolemia what happens? The decreased preload, that in inferior vena cava is collapsed. You have to give bolus. Then this hypovolemia can be tackled. And it will cause decreased cardiac output and shock. And so, similarly, that will cause decreased oxygen carrying capacity and so accentuate the shock. Myocardial dysfunction may be due to post-asphyxia. After birth asphyxia, the heart is failing. Heart fails. So you have to support the heart. In extreme premature, that in premature, the myocardium are not developed. So most of the neonatal shocks occur in the premature. So you have to take care of the myocardium. In septic shock, what happens? Both the heart and peripheral, both are, means that pump and pipe, both are affected. The heart is also affected and vessels are also affected. Then the septic shock is the problem. And in viral myocarditis, viral infection, myocardium also get inflamed. So that is called myocardial dysfunction, decreased cardiac output, decreased oxygen delivery to the tissue. So oxygen, this is the neonatal shock. And there is selective vasoconstriction, a vasodilatation. If the neonatal shock, there is selective. What happens? The vital organs like brain, heart, and lungs, in these systems, there is vasodilatation. The regulatory system protects these vital organs. And otherwise, the non-vital organs like skin, splanchnic, kidney, there is vasoconstriction. So they are affected most. So initially, these non-vital organs are affected, but if the neonatal shock is severe, then the vital organs are affected. So in Ramayana also, the Lakshman get murchit and Sanjeevani Bhuti was brought. What is Sanjeevani Bhuti? That was inotrope. And this inotrope is a very important drug. This engineer the cardiovascular system, heart, vessels, and everything can be engineered by this inotrope. So you have to know what inotrope and how it should be given. And this definition and terminology, inotrope, myocardial contractility, inotropy, chronotropy, heart rate is increased by firing the sinoatrial node. Lysotropy, relaxation of myocardium. Dromotropy, conduction velocity of atrioventricular node. Bathymetropy, increased degree of excitability. So that may cause arrhythmia. So vasopressors increases vascular tone. So these are the definition and terminology of inotropes. And in inotropes works in different adreno receptor. That alpha 1 it will cause vasoconstriction. In beta 1 it will cause inotropy. Inotropy means the contractility of heart will be increased. Heart will contract more powerful. Chronotropy, the heart rate will be increased. And beta 2, there will be vasodilatation. Though vasodilatation is also important to facilitate the blood supply in the vital organs. So the vasodilatation is also very important. Dopamine will work as a vasodilator, vasoconstrictor in many ways. So dopamine is a very good drug, but the dose and how it should be given, it is important. The use of dopamine in transitional period is very important. That transitional period means that just after birth, by intrauterine period, what happens? The heart left ventricle is not working properly, and right ventricle is only working, and blood is bypassing to the ductus venosus, and so left ventricle is very weak. So in transitional period, if in premature, that will needs this dopamine, that will increase myocardial contractility, cardiac output will be increased, oxygenation will be increased, decreases, but very important that it decreases pulmonary vascular resistance. So it is very important in PPHN. So this drug is used especially in the birth asphyxia, or if in the premature, it should be used. And limitation is that decreases peripheral vascular tone and no increase in MAP. So if there is hypotension, so this drug should be not used. First you have to increase the blood pressure, and then you should use this drug. Use of epinephrine. Epinephrine means adrenaline. Adrenaline is very important in PPHN because it increases the myocardial contractility. MAP in high dose is also in higher dose. If you are using mean arterial pressure is also increased. Systemic vascular restriction in higher dose. So it is very good drug if there is shock. And limitation is no change in pulmonary vascular resistance. So it should not be given in PPHN. And because pulmonary arterial pressure, there is no change by this adrenaline. And norepinephrine is very effective in vasodilated septic shock. If there is septic shock, then you should take the help of noradrenaline. And milrinone is a very good drug because it has a very effective in PPHN and increases myocardial contractility, oxygenation will be increased, decreases ductal shunt. Ductal shunt means that if there is right to left shunt, then it will be decreased. So it decreases the dose of nitric oxide. If you are giving nitric oxide and if you are using milrinone, the dose of nitric oxide will be also decreased. Lactic acid will be also decreased. So limitation only is the decrease. If there is hypotension, you should first maintain the blood pressure, then you have to give the milrinone. Vasopressin, again a very good drug, but it should be used in a very disparate case because it causes vasoconstriction in all the system. Corticosteroid is also should not be used in newborn, but in very low dose, if inotropes are not working properly, if you are using in very low dose, 0.5 to 1 milligram per kg body weight, that will accentuate the effectivity of inotrope, and that should be used in very low dose. And investigation, again, the first line is like the RBC, CBC, CRP, serum calcium, serum electrolyte. Second line is the blood culture, blood gas, serum lactate, chest X-ray. Third line is the ECG. Cranial ultrasound is very important. If you have to take the help of ultrasound in neonatal shock, because if you are taking the help of ultrasound, that you can see through the cranium, through the anterofrontal, you can see whether there is intracranial intracranial hemorrhage is there or not. And through this functional echocardiogram, you can see every part of the heart, vessels, and everything will be seen. And accordingly, you will treat the cause, and inotrope can be used by the functional echocardiogram. And serum ammonia, serum ketone, PT and APTT should also be monitored. And the vitals should be taken care. Heart rate, you have to monitor by pulse oximetry. Pre-ductal and post-ductal oxygen saturation is very important. That pre-ductal means that if you are taking oxygen saturation in right upper limb, and that is pre-ductal. Now post-ductal is that the oxygen saturation in both lower limb, post-ductal. And if the difference of the pre-ductal and post-ductal is more than 5%, then you should think about PPHN. Because in PPHN, due to left to right turn, it will be, the pressure difference will be increased. And capillary fill time, as you see, by pressing the sternum, if it is more than 3 to 4 seconds, cold extremity, cold and peripheral temperature and difference of more than 1 degree centigrade should be taken as a serious matter. And blood pressure with the proper size cuff and covering 2/3 of the upper limb in 4 limbs should be taken. Pulse to be palpated ideally in all 4 limbs. Femoral and femoral particularly very important. But because if there is shock, the femoral pulse will be weak first, then the upper limb. So generally the brachial pulse in the upper limb and femoral pulse in the further limb. Perfusion index. What is perfusion index? In pulse oximeter, just a bar going up down is perfusion index. And if it is more than 50%, then the perfusion index is good. You can see also that in pulse oximeter, if there is shock, the sound of the pulse oximeter also changes. So it is the perfusion index by which you can manage, you can assess whether shock is going or not. The summary of adaptation. Just after birth, after separation of the placenta, what happens? We have cut the umbilical artery, so the systemic vascular resistance is increased. Afterload is increased. And so the left ventricle has to work hard. So the left ventricle has to adapt, and they have to work hard. Otherwise, there will be cardiac failure. So the persistence of PDA and PFO will complicate the matter. So we have to give, if there is any this prematurity, we have to take the surfactant administration, and so hypotension and hypoperfusion should be managed. The differential diagnosis is the sepsis. In neonatal shock, sepsis, cardiac congenital heart disease. hypovolemia, hypoglycemia, in CNS, seizure, intraventricular hemorrhage, metabolic disorder may be the cause of neonatal shock. The most important upcoming tool is functional echocardiogram. Now that the functional echocardiogram training workshop is going on all over India, and we should work hard and we should know what is functional echocardiogram, and then only we can manage this neonatal shock properly. What happens that in some time what happens due to duct dependent congenital heart disease like hypoplastic left heart syndrome, coarctation of aorta, left output obstruction lesion, right output obstruction lesion. What happened? Baby was given clean sheet. Baby is okay, but just when baby comes for re-examination or sometime on T or third, baby is not working, doing well, and you are examining a baby in shock. Baby is, the pulse oximetry, you are finding the oxygen saturation only 50 or 60, and baby is going to gasp. Why? Then parents ask, why you have not diagnosed this congenital heart disease earlier? So, this is a very
Excuse me, sir.
problematic.
Time is very short. Kindly finish your
Okay,
speech.
thank you. So, you have to take help of screening of heart disease by pulse oximetry. If you are doing pulse oximetry saturation, this can protect the sun-dependent critical congenital heart disease. So, if the oxygen saturation is in the preductal, in the right upper arm, is less than 90%, and difference of upper limb and lower limb is 3%, more than 3%, then you have to do echocardiogram before giving clean check to the newborn. So, within 24 hours, everybody should be screened for critical congenital heart disease by pulse oximeter. So the protocol, I will go short, and you know everyone is knowing. So the take-home message that high suspicion of duct-dependent congenital heart should be taken care. 4-limb pulse oximeter and blood pressure should be taken. Sole blood pressure is nothing. You have to take continuous blood pressure. BP is in collaboration of other parameters is important. Functional echocardiogram is very useful tool. Comprehensive approach of the functional echogram with clinical indicator is very important. Thank you if I have not made sleepy.
Thank you, sir. Thank you for your deliberate speech. Due to shortage of time, there will be no question and answer in this speech. I request all the audience that if any confusion exists, ask Dr. Shravan Kumar during the lunch session or on his personal WhatsApp. Thank you.
Thank you so much to Dr. Shravan Kumar, sir. And now we are going to cover our next topic, which is MR elimination. And I'd like to request all the chairpersons to get back to their seats after getting felicitated. Thank you so much, everyone. Thank you so much to all the chairpersons. And now, to discuss the next topic, which is MR elimination, we are going to invite all the chairpersons, Dr. Mithilesh K. Singh, the Director of Care, Kilkari and IVF Center, Darbhanga and Jayanagar. Then I would like to request Dr. Om Prakash Jha, the Chief Consultant at Krishna Clinic, and Dr. Suraj, Darbhanga Children Hospital is founded by Dr. Suraj, a pediatric and consultant neonatologist in Darbhanga. And now I'd like to request the speaker, Dr. Shekhawat Singh Bhartiya, WHO, to please come over the stage and to start his presentation.
Hello.
Dr. Shekhawat Singh Bhartiya. Okay, finally he is here. So I'll be requesting the chairpersons to first introduce the audience to Dr. Shekhawat and then we will continue. Thank you. I request everyone to please settle down. I request all the doctors here to please settle down as we are going to start our next topic, which is MR elimination. Please settle down so that we can start. Thank you.
Hello. Dr. Shekhawat Singh Bhartiya. He has done his MBBS from Gandhi Medical College, Barakatullah University, Bhopal, Madhya Pradesh, and MD in Community Medicine from Gandhi Medical College, Barakatullah University, Bhopal. He has a lot of notable achievement, like successfully led the polio eradication program in India's toughest geographical and highly endemic areas. And as a professional narrative, he is currently working as a sub-regional team leader since January 2023 to present at Darbhanga, Bihar, WHO and PSN. Previously, he has worked as a surveillance medical officer, lecturer, and for Care India. A wide range of original research articles have been published in a reputed index journal on cardiovascular disease, diabetes, hypertension, metabolism, and biomedical waste management, as well as public health institution assessment. Now you can proceed, sir.
Thank you, Chairperson. Good afternoon. Good afternoon, esteemed doctors and distinguished guests. I'm honored to be here today on behalf of WHO India Bihar region to provide you with the latest updates on our efforts to eliminate measles and rubella. We are gathered at Bihar PEDICON 2023, a prestigious event that brings together renowned experts in pediatric medicine. Together, we recognize the urgent need to address vaccine-preventable disease, particularly measles and rubella, which continue to have a significant impact on lives of children worldwide. Before we proceed, I would like to extend my heartfelt gratitude to the dignitaries of the Indian Academy of Pediatrics Darbhanga branch for providing me with this valuable opportunity to share the progress and insights with you. Thank you. This is the outline of my presentation. We will discuss about the basics of MR elimination, national level update, BPD, surveillance case definitions, and steps for case investigation. As per the Indian Expert Advisory Group for Measles and Rubella Elimination, they identified some strategic objective to achieve the MR elimination. And the two basic and field level objectives are, number one is to enhance the measles rubella containing vaccine coverage with 2 doses, at least 95% at national level, and then an effective and sensitive case-based FR surveillance. Apart from these two objectives, another is the aggregated FR laboratory network that is already well established and working in India, then rapid response to measles and rubella outbreak investigation and other linkage with SDGs and integrated programs. As we proved in last 2 decades that measles and rubella is manageable programs to eliminate, because in last 2 decades there were more than 95% reduction of measles mortality seen in Southeast Asia region, including India, and around 80% of this measles mortality in Sero, India contribute more than 80%. As far as the cases of measles cases are concerned in India, in the current year of 2023, Bihar contribute the second largest number of measles cases, second to Uttar Pradesh. And when we see the distribution of measles cases and outbreak, we can see in Bihar especially, almost all districts of Bihar having huge number of outbreaks and active measles transmission. That is one concern, and such kind of huge number of, I think, 257 measles positive outbreak and 5 rubella positive outbreak in the current year, it shows there is definitely some significant immunity gap also. And when we analyze the data of lab confirmed measles cases as per age distribution, majority of cases, more than 90% are belongs to less than 15 year of age. This is at the national level, and at state level, I think data is approximately same. For rubella concerns, for rubella, lab confirmed rubella, majority of cases again less than 15 year of age, but in rubella we are seeing significant cases, especially in Bihar, in more than 15 year. And that is the real concern for rubella and for congenital rubella syndrome. One of the most sensitive indicator for measles rubella elimination is the indicator of FR surveillance, that is non-measles, non-rubella discord rate. And as per GOI standard, it should be at least 2. Unfortunately, India achieved in 35 states with these indicators. In Bihar, definitely Bihar is leading at national level by improving its surveillance, and this is one of the highest FR surveillance in India. As far as the vaccination coverage is concerned, that is really very important, because for to achieve this target, there is a need to achieve at least 2 doses of measles rubella vaccines, more than 95%. As per the current data, 49% districts of India achieve the first dose of measles and rubella containing vaccine. It may be MR vaccine or MMR vaccine. And the target is to achieve the 2 dose, means MR2 vaccines. At national level, the coverage is 92%, but only 39% districts of the India achieve this level. Still 61% districts are not able to achieve the 95% of measles rubella containing vaccine coverage. As far as the measles and rubella case definition for elimination is concerned, this is very important to understand the program, that the absence of endemic measles transmission in a defined geographical area for more than 12 months. Here, geographical area, it means the district. For this program, district is the unit to be declared as an elimination. It is verified under it has been sustained for at least 36 months in the presence of high quality surveillance system. Same definition is applicable for rubella also. But as we are saying, there should be at least 12-month period of no transmission. But almost all districts of Bihar has incidence of measles in 23. So unfortunately, in this year, as per the target of GOI, no single district of Bihar is eligible to achieve the level of measles and rubella elimination. Government of India is working with multiple stakeholders. IMA and IAP is one of the highest valuable stakeholders, especially for the academic and field purpose in India. And they are also supporting the program, especially for providing the awareness and importance of vaccination in the community, especially in the areas where vaccination coverage really concern, like vaccine resistance area, resistant area, or vaccine refusals area. And another more and very significant contribution of this IAP and IMA members is they are supporting in the surveillance system. And as we see at national level, even in the Bihar level, definitely surveillance system really doing great. And majority of cases belong to pediatric age group, so definitely credit goes to all pediatricians. We all are aware of what is measles and what is rubella. Everybody knows post-measles complications. There is saying measles, post-measles complications can anything. Measles virus can do any kind of complications in human body except pregnancy. There is so broad spectrum of post-measles complications. As far as rubella is concerned, rubella itself not a very severe disease, but when it occurred in first trimester of pregnancy, first trimester, it may be very dangerous. The potential of congenital rubella syndrome is very severe. It may include congenital hearing impairment, congenital cataract, glaucoma, congenital heart disease, microcephaly, mental retardations, organ development failure. There are so many problems it can be there. Now here is the what is the take home, what will take home message, and what is my expectation of WHO from IAP. That is, although you people are really doing great work in vaccine preventable disease surveillance, but this is a very high time, and we are expecting such kind of support as you provided in earlier also. So for this, there is some VPD's case definitions, and the ultimate purpose of this my presentation is just to understand what is the case definition, so that we can notify these cases to concerned district authority. For measles rubella elimination, FR, fever and maculopapular rash surveillance is the most important. And case definition is very simple. Fever, any person having fever and maculopapular rash. irrespective of age. Another BPD is the diphtheria. We are not going for the clinical discussion, the time is very less. The case definition for diphtheria. These all case definition are meant for purpose of frontline worker or field worker. They are not very much clinical. So whenever we are getting case definition in any patient, please report it. But for a specialist, if you are feeling this is a case of diphtheria or pertussis or measles, although it's not meeting the case definition, but your clinical diagnosis, you can report it. Case definition is for frontline worker. You are the specialist, you can report even beyond case definition. But again, case definition वाले case तो हमको report करना ही है. Yeah. So diphtheria, as we know, is the illness of upper respiratory tract infection characterized by laryngitis, pharyngitis, or tonsillitis. And if you are seeing adherent pseudomembrane in such kind of cases, this is suspected case of diphtheria and should be reported, should be notified. Another BPD that is under surveillance is the pertussis, and case definition for this pertussis is any person at any age with having history of cough lasting at least 2 week duration with either of one symptom. It may be paroxysm of cough, or it may be inspiratory poop, or post-acid vomiting. Either of one symptom with 2 week duration of cough is the suspected case of pertussis, should be reported to your nearest district authority. In case of infant, definition is little bit different. For infant, the case definition of pertussis is the case having apnea with or without cyanosis with any duration of cough. Another BPD under surveillance is the neonatal tetanus, and the case definition is very simple for this. Any neonate was having normal ability to suck and cry during the first 2 days of life, and whom between 3 and 28 days of life cannot suck normally, become stiff, or has a convulsion, spasm. It may be a broad range. It may up to the opisthotonus. So such type of cases should be reported as neonatal tetanus. And the last one is the poliomyelitis. Although LDI is polio free since 2011, there is no polio case in India, but still in some neighboring countries and in the world there is active transmission of poliomyelitis. That's why we need the polio surveillance, that is called acute flaccid paralysis surveillance, AP surveillance, for 2 reasons. Number 1, to ensure that we are still polio free, and number 2, if there are any cases that can be imported to India, we can identify immediately and plan containments. For acute flaccid paralysis, the case definition is very simple. I think everybody will be aware because this is a very long-lasting program starting in 1997. The case definition is very simple: sudden onset of floppiness or paralysis in any part of the body up to the age of 15 years within 6 months of onset of paralysis, irrespective of clinical diagnosis. In case of AP, actually we are doing surveillance for floppiness or flaccid paralysis. It may be a case of Guillain-Barré syndrome, traumatic neuritis, foot drop, transverse myelitis, flaccid kind of monoplegia, paraplegia, hemiplegia, quadriplegia, transient paralysis, facial palsy, bulbar palsy, neck floppiness, any kind of disease, irrespective of clinical diagnosis. If you are showing any case that is having history of flaccid paralysis under 15 years of age, kindly notify this case. And what is the notification? Notification means please inform basic information, basic identification information about the patient, like name, parent name, complete address, contact number, date of onset, to your nearest district immunization office or WHO office. In Bihar, every district has WHO office. So you can report these cases to them. And that is the ultimate purpose of this presentation, ki kindly just to reorient them and update them regarding the case definition, how to notify the case and to whom. And whenever we get any case from anywhere, we investigate the case within 48 hours of notification, do some specimen collection as per the standard protocol, also conduct active case survey in the community to identify the additional cases of BPTs, and if there is any kind of outbreak, we investigate the outbreak in detail. This is the specimen collection. For example, in case of AP, we usually collect 2 stool specimens, preferably within 14 days of onset of paralysis, but we can collect up to 60 days of onset of paralysis, 24 hours apart in a proper cold chain. For FR surveillance, that is reported for measles and rubella, there are 2 kind of specimen we are collecting. One is the throat swab, and window period for throat swab collection is onset to first 7 days. and serum is from onset to 28 days. For throat soap, viral transport media is the medium. Diphtheria, preferably we collect the throat swab in MS transport media from 2 days to 4 days from onset. In case of diphtheria, onset of sore throat considered as a onset of diphtheria. In case of pertussis, there are two types of specimen we collect. One is the nasopharyngeal swab, two specimen from 2 week to 4 week from onset. In case of pertussis, onset is the onset of coughing. And the nasopharyngeal swab is collected in MS transport media with charcoal, and serum from 2 week of onset of cough to 12 week. And these all media and kits vagara available with WHO office, and we usually provide these kits to DIO and their nearest PSC, CSC offices. Whenever case comes on our notice, so our team is working for that. They immediately contact the case and supply the all essential logistic for specimen collection. Ultimately, as we proved during the polio eradication, I really thank you for your contribution in polio eradication in India. Now it's time for the measles rubella elimination. So this is my humble request on behalf of WHO. Let's join us hand to eliminate measles and rubella from India. Together we can protect the health and well-being of our children. Thank you very much. Thank you, IAP Darbhanga. Thank you.
Thank you, Dr. Shekhawat, for the wonderful speech. Any questions from the audience?
Thanks, Dr. Shekhawat. As we are facing challenges, we appreciate your effort and support of the government of India and Bihar. The MR was, the rubella was the very important thing to be covered, and measles was such a killer that in previous year in Mumbai we faced many cases. So promoting all these things and surveillance, which is the main part. One thing, not of you, but we think that if the government of India will change MR with MMR, because a lot of pediatricians of our Bihar are saying that we are every third percentage of mumps this year. And long-term sequence of the mumps, it may be infertility due to bilateral orchitis and this ophiritis. It may create, it also creating the pancreatitis. So this is not your domain, but I am thankful to you that you are supporting all the immunization events in the Bihar, and especially the MR and pneumococcal vaccination, all the vaccinations. So very, very much thanks to you.
Thank you, sir.
Thank you very much, Dr. Shekhawat. Let's go to the rear part of this hall to collect the memento. Thank you very much, everyone. Speaker and chairperson must go.
Thank you so much, Dr. Shekhawat, sir, for your presentation. And now let's cover our next topic, which is on how to follow and care very low birth weight babies. So to cover this topic, our speaker would be Dr. Alka Singh. And to chair this session, I'd like to invite our honorable chairpersons. So starting with the first name, Dr. Vinay Ranjan, who is the head of Department of Pediatrics at Mahavir Vatsalya Hospital. Then Dr. Amrita Mishra, who is consultant pediatrician and director of RB Memorial Hospital, Darbhanga. And Dr. Binit Singh, who is consultant at Navdeepak Children's Hospital, Darbhanga. Again, all of the chairpersons are requested to come and join. Dr. Vinay Ranjan, Dr. Amrita Mishra, and Dr. Binit Singh. And our next keynote speaker is going to be Dr. Alka Singh, and we are going to cover the topic, follow and care of very low birth weight babies. And Dr. Alka is here, so I will be requesting the chairpersons to first introduce about her. Thank you, everyone.
It is my distinct pleasure to introduce Madam Dr. Alka Singh, a distinguished professional in the field of pediatrics and neonatology. Madam is a highly accomplished individual with a remarkable background and an extensive list of achievements. With a multitude of qualifications, including MD, PhD, and MRCP UK, Madam has served as a professor and former head of the Department of Pediatrics at NMCH Patna. Her dedication to the field is further evident through her role as the Secretary of the National Neonatology Forum 2013-14, President of IAP Patna Branch 2019, and Secretary of the Intensive Care Chapter Bihar 2017-18. Currently holding the post of Vice President at IAP Bihar Branch for the year 2023, Madam has been recognized for her contribution with prestigious awards such as the Purvanchal Shishu Visheshagya Shiromani Award, East Zone IAP, and the Academic Excellence Award from Bihar IAP. With such an impressive array of accomplishment, Dr. Madam embodies excellence in the field of pediatrics. Please join me in extending a warm welcome to Madam Dr. Alka Singh.
And to chair this session, one more doctor is requested to join, Dr. Prabhat. So thank you so much, Dr. Prabhat, for coming here and for joining. To chair this session, thank you so much. Over to ma'am.
Thank you, Dr. Amrita, for such a nice introduction. And first of all, I would like to thank the organizing team of the 32nd Bihar PEDICON, especially Dr. Ashok, Dr. Om Prakash, and Dr. Salim. And I am privileged to give my deliberation in front of my guru, Dr. Professor Bhola Nayak sir. I have done my MD from Darbhanga Medical College in the year 85-87. So it brings back many beautiful memories as I come here and to give this talk. So today I have taken up a very important topic, and it is follow-up care of very preterm and very low birth weight infants. So we see that when we care of a baby in the NICU, from the NICU environment, the baby is discharged and then it comes out into the outside world. Then what will happen outside, and the type of care he was receiving in the NICU and the challenges he faces in the home environment and in the society, that has to be taken care of, and this is a very intricate topic, and there has to be a very definite follow-up, structured follow-up for this. So now the focus, 25 years back, the main aim was just to care for the babies and just to save them somehow, the very preterms, the very low birth weight. The aim was just to save them. But now the focus has shifted from mere survival to quality of life among the survivors. So aggressive strategies to follow up these babies have been taken up, and they are replacing the passive and neutral approach. Previously, babies were saved and then they were just left to themselves or followed up in very few circumstances, and not much attention was focused on what was happening to them actually in terms of growth, development, and neurodevelopmental outcomes. Now, follow-up programs provide optimization of health status of NICU graduates. It is, the NNF has made it mandatory that every neonatal unit must have a structured program to follow up the babies, the very low birth weight babies, for its accreditation. So every NICU must have this structured follow-up program, and it should be strictly adhered to. Now, follow-up doesn't mean just one or two follow-ups. It is a dynamic process. So as it evolves, as the baby grows up, develops, and then increasingly interacts with the environment, you come across problems that he may show in all these areas, and you can pick up the problems early and think of some intervention that might be of help to the baby. So it has to be a dynamic process and not a static process. Why should we follow up? The very preterm. By the term very preterm, we mean babies less than 32 weeks of gestation. And very low birth weight, of course, is less than 1.5 kilo. So growth and development has to be assessed. Any developmental delay has to be detected, and provide primary care guidance to the parents. That is very important. We are working with newborn babies since such a long time, and but still we find that in spite of so much advice that we are giving and so much of efforts of the UNICEF and other bodies, parents are not so much aware, or they are not so much vigilant, and still they stick to their former beliefs, and the care that these babies should receive in all the areas, they are not strictly adhering to them. So guidance to the parents regarding the feeding, that is the most important. Then the immunization. Still we are finding many babies who are either partially immunized or non-immunized. Provide treatment of illnesses, like if there is some problem in the baby, they should go and seek medical help. And manage children with medical, motor, and cognitive problems. So what is the aim of this follow-up? The aim is to just pick up the problems. Just pick up, and then if you find a baby with any discrepancy, any lag, you will have to refer to a structured follow-up center and do early intervention, because early intervention will help a lot. Nowadays, there is a district early intervention center started by the government in various hospitals, and there the babies, wherever a baby is picked up, either in the periphery or anywhere, those babies are referred to the center, and interventions are done. Even interventions can be done at any facility, whatever problem the baby is having, that has to be addressed in any department. And the earliest possible detection of abnormalities, so that early intervention can be started to achieve a near normal neurological, developmental, and functional outcome. What is the criteria? Which babies do we are talking about? This is less than 1,500 gram, very low birth weight, and less than 32 weeks, very premature. Where to follow up? So this is actually a continuum of care. So first the baby was in NICU, then he is discharged home. So at home also, there is a system of follow-up, which we will talk about in the next few slides. And then some babies, the high-risk babies, whom we think that they should be called, they are called to the follow-up clinic. So it is basically a continuum of care from the NICU to the home visits to the follow-up clinic. Now, this is the blue book. And this is developed by the Kerala Institute of Medical Sciences and Child Development Center. And it is being followed in more than 200 NICUs in India. So this is, actually it is like a diary, and every day there are pages, and information is written in them, so that there is a structured follow-up. It is a checklist. It is right from the birth up to 6 years, this diary is maintained. So this is just a brief account of what it contains. Page 1 contains information of parents, obstetrician, referring pediatrician, and their contact details. Then page 2 gives the birth details, the gestational age, birth weight, date of birth. Then page 3, list of antenatal and neonatal risk stratification, like what were the risk factors and how you would stratify the babies according to high risk or low risk group. Then page 4, risk stratification based on the perinatal risk factors. Page 5 contains the growth charts. So growth monitoring we will talk about later. That is of utmost importance, and mostly we see that these things are not being followed everywhere. In all NICUs, charts are not being maintained. So that is a very important part which you have to address. And then in page 6, there is a plan to introduce the early parent participation program. So parents should take early participation in the care of the babies, and we have already started this program in our NICU at NMCH, and there are several trainings going on regarding this, the early parent participation program. Then developmentally supportive care. We will talk about this also, what to do which can stimulate and enhance the development in these babies. Then page 7 contains health education session for parents by development follow-up teams. Parents are the utmost important in part of baby's life, and they can help a lot. And 8 gives a list of medication, and next page, 9th page, test reports, lab and imaging. 10th is about physical and neurological examination before discharge. 11th, pre-discharge checklist. 12th is about vision assessment. 13, hearing assessment. And then after that, there is 14 to 19, there is 1 page each for development assessment at 4, 8, 12, 18, and 24 months of corrected age. And then annually till 6 years of age. So this is just a brief description about the Blue Book so that everybody is acquainted as to what you have to do and what areas you need to address. Follow-up by whom? It has to be done not by one person, but by a multidisciplinary team according to the problem that is detected in the baby. So first, foremost will be the neonatologist who will see and detect the problem, or the pediatrician. Then follow up, according to the problem he has, he can be followed up by neurologist, orthopedician, child psychologist, occupational therapist. And nowadays, there is the home-based follow-up carried on by health worker, ASHA. Now, in the National Rural Health Mission, they have started this home-based neonatal care, and this includes home visits for all newborn babies, according to the following schedule by ASHA. So, preterm and low birth weight babies are followed up. Those babies who are born at home, they will be followed up on day 1, 3, 7, 14, 21, 28, and 42 days. Those who are hospital-born babies, for 1 day they stay in the hospital. So day 1, they are being seen in the hospital itself, and then later 3, 7, 14, 21, 28, 42, these will be done. Then after that, after 40 days, frequency becomes less, and then at 3, 6, 9, and 12 months of life. Now, after discharge, development assessment has also to be done. Development assessment is done at 4, 8, 12, 18, 24 months corrected age, and then annually up to 6 years of age. So corrected age has importance in the case of premature babies. That means the chronological age minus the number of months or weeks earlier they were born. So you have to correct the age for many assessments that you will do later. When the ASHA visits at home, the first the main aim is to ensure a smooth transition from nursery to the home environment, and they see the weight, the length, the head circumference, give advice about immunization, and if some immunization is due, they make them aware of any feeding problem that the baby may be having or any other problems. Subsequent visits, again, same thing, history, anthropometry, and then as the baby is growing, the milestones of development, vision, speech, language assessment, and reinforced breastfeeding. So this is again and again reinforced for exclusive breastfeeding up till 6 months of life. Assess functional skills of daily living. See whether the child is going, as the child is growing, he is able to do the things that he is supposed to do at that following age. Then growth assessment has to be done, and evaluation of the growth pattern has to be seen to. So these will be plotted. Until unless you plot it, you can't be sure whether your baby is growing properly. So there are intrauterine growth charts and postnatal growth charts. So ideally for a preterm baby, intrauterine growth charts are used, and they represent reference curves closer to the normative standards for preterm babies. They depict cross-sectional measurement of weight, length, head circumference at birth, and the 50th centile constitutes the optimum weight that postnatal growth should achieve. But even with the intranatal growth chart, there are certain fallacies. They assume that the antenatal period has been uneventful, and the disadvantage is that the postnatal fall in weight is not represented. Then there are postnatal growth charts. They represent longitudinal growth over a period of time, and they depict the normal postnatal weight loss, but again, the disadvantage is that it is dependent on ideal postnatal conditions, which may not hold good for every baby. So there are several types of charts, and all charts differ slightly from each other. Not all charts are not the same. Postnatal charts that are commonly used for growth monitoring of preterm babies, very low birth weight infants, are Ehre-Kranz and Intergrowth 21 charts. And for preterm infants as young as 22 weeks of gestation, we have the Fenton's chart. This is very commonly used in ICUs, and you can chart it from 22 weeks up to 50 weeks. Once the baby reaches 40 weeks of gestation of postmenstrual age, then you can use the WHO growth charts also. But whenever you are plotting the weight of a baby on a WHO growth chart, or the length and the other parameters, you have to use the corrected age up till the age of 2 years, and after that you can take the chronological age. Because the very preterm babies will have a slower growth rate in the beginning. So this is the Fenton's chart. It has all the 3 parameters: length, head circumference, and weight, and you can have, it is also gender specific. Very preterm, very low birth weight infants suffer significant growth lag in the postnatal period and show significantly slower growth of length and head circumference. But if the growth curve runs parallel to the normal curve, then you can think that my baby is growing, it is a healthy growth pattern. But if the curve plateaus or the trajectory falls off, then this type of babies will need evaluation. Why the baby is not gaining weight, why is he losing weight, or why his weight has become static over a period of time. Immunization, everybody is worried about immunization. So the very preterm infant should receive immunization according to the same schedule. That means according to the chronological age. And questions have arisen about hepatitis B, but thriving babies, thriving infants should receive hepatitis B. They can be given as early as 30 days, or if the baby is admitted in the NICU and is going to be discharged at say 15 days, 21 days, he can be vaccinated at that time also. BCG vaccine is safe and effective in preterm, and parents should receive pneumococcal influenza vaccine. Then development assessment, neurological, Emil Tyson neurological assessment, it is a good screening test to decide which babies will need more elaborate developmental test, but it does not test the mental component. Development assessment should be done using corrected age. Gold standard is the differential ability test, and done at 1 year, it gives a good idea about mental development. It is standardized from the Bailey scale of infant development by Fatak in 1961 and now called Baroda norms, and used by child psychologists. This is the toolkit. Then vision assessment. You know that these babies are subjected to oxygen therapy in the NICU. Their incidence of ROP is as high as 25 to 55% in VLBW babies, and there is incidence of blindness in 2 to 9%. So ROP screening should be done for all babies of 34 weeks gestational age or birth weight less than 2 kilo at 4 weeks of life. And babies less than 1200 gram and less than 30 weeks at 2 to 3 weeks of age. Hearing assessment, that there is hearing loss incidence in VLBW is 2 to 11%. There is auditory dyssynchrony, auditory neuropathy. So that should be done. Auditory brainstem response should be done after 34 weeks of post-conceptional age. And otoacoustic emission, there's another test, and it is a very effective cross-screening test. Cranial ultrasound on day 3, 7, 21 to identify intraventricular, periventricular hemorrhage, hydrocephalus, periventricular mucomalacia. And any infant with abnormal USG or neurologic finding, they should have CT, MRI, EEG at the age of 3 months. So these are the problems they may have: cerebral palsy, visual handicaps, mental retardation, motor coordination, depression, anxiety, clumsiness, ADHD, language. More than 50% of extremely low birth weight babies may require some educational assistance. And systemic disorders, bronchopulmonary dysplasia is very common, gastroesophageal reflux, feeding difficulties, nutritional anemia, rickets. Then early intervention. So, as I said before also, problems have to be picked up for early intervention. And developmentally supportive care. What is this? It consists of environmental and interventional options in hospital units and homes as early as possible, and both medical personnel and parents should be involved in this so as to decrease stress and optimize neurodevelopment. So stimulation has to be done for body movement, vision, hearing, touch. And there are many articles that how the 5 sensory organs, if stimulated, lead to better emotional and cognitive development in the premature babies. Modifications have to be done in NICU, like dimming of light. This is the nest showing how the baby was in the uterus. So babies have to be nursed in this type of environment. The non-nutritive sucking, pallidi feeding, kangaroo care, these all have to be encouraged. And baby should be kept as symmetrically as possible, and swaddling. See, the baby is wrapped up and he has kept in a midline position, and there should be boundary around the baby so that he feels secure as if he is in the womb. Parental counseling has been done. Danger signals have to be taught so that they can return when they find all these problems. And one or two things or more I have to say, that auditory stimulus, mother's voice is the best auditory stimulus. For vision, mother's face is the best visual stimulus. Tactile, mother's touch is the best tactile or olfactory stimulus. Mother's smell and smell of mother's milk, those are the best stimuli for the baby. And when the mother holds the baby and rocks it, that is the rhythmic breathing and the chest movement, they are the best kinesthetic stimulus. So keep in mind that newborn babies are surprisingly alert. Touch is the natural extension of stimulation. Not nutritive sucking improves weight gain. Rocking, walking, or swinging stimulates the vestibular system. Babies comforted through vestibular stimulation show greater visual alertness. Music stimulates the auditory brain centers and connects powerfully to babies' emotions. The take-home message is a well-organized linkage between NICU, high-risk clinic, and home will improve the morbidity, mortality, and quality of life among the very preterm and very low birth weight survivors. Thank you.
Thank you, Dr. Alka ma'am, for your nice and wonder talk. I have one question. Do you advise for cardiac evaluation in preemie before discharge or in during the follow-up case?
Not routinely as yet, it is not the strategy, but there have been studies, like there was one study in which pulse oximeter was being done for all the babies admitted in the NICU, but that is not actually routinely being done.
Thank you, ma'am.
Thank you, ma'am, for your elaborative description, because all neonatologists, we are doing our best in treatment, but we are somehow miss the follow-up. Yes. So one thing we have learned is blue book concept. we must apply in our clinics to follow up, especially the preemie baby, to intact survival of the baby.
This blue book is available on net.
Yeah. Thank you, ma'am.
Thank you, ma'am, for the beautiful deliberation. The keynote is an robust.
Mic change, please.
Thank you very much. Let's go to the rears.
Thank you so much, ma'am, and thank you so much to all the chairpersons. Now I request each one of you to please move to the rear side of this hall to get felicitated. Thank you. And now we are going to continue the next topic, which is rickettsial diseases. And to chair this session, I'd like to invite on the stage Dr. Ram Gopal Jain. He is a leading pediatrician of Muzaffarpur and professor and head of Department of Pediatrics at SKMCH. So firstly, we'd like to invite Dr. Ram Gopal Jain. And then I would like to invite the other chairperson, Dr. R.B. Ranjan. He is Dr. R.B. Ranjan. He is the former civil surgeon at CNO Department of Health, Bihar, and he is former assistant professor, Department of Pediatrics at NMCH. And the third chairperson, Dr. Vivekanand Paul, the senior resident pediatrics from Darbhanga Medical College and Hospital, Lahiriya Sarai, from 2016 to 21. Practicing in Darbhanga since 2016, also a life member of IAP since 2013. So thank you so much to all the chairpersons. Now I'd like to invite our next keynote speaker to give his presentation on the same topic, rickettsial diseases, Dr. Nigam Prakash Narayan. And again, it's a request to all the chairpersons to please introduce the audience to Dr. Nigam Prakash Narayan. Thank you so much, and over to chairpersons.
Mike, sir. Mic on नहीं है.
Check.
Hello. Hello. It is my pleasure to introduce Dr. Nigam Prakash Narayan. He is a retired professor and head of pediatrics, Patna Medical College. He has been examiner of the Royal College of the Pediatrics and Child Health, completed MRCP from Royal College of Physicians, London, served as a secretary IAP Bihar State Branch, secretary of the IAP East Zone, president of the IAP East Zone. He was a vice president of the infectious disease chapter of IAP 2008 and EB member Bihar State IAP thrice. Past member of the editorial board of the Indian Pediatrics and Indian Journal of Pediatrics, nominated twice as a governing body of the Central NNF. EB member of the Central IAP twice in 2011 and 2018. Awarded FIAP in 2003, also awarded Poiner Award of the East Zone IAP in 2000. Also awarded FNNF for his contribution to newborn care. Contribution to small and publications of IAP chapters are many. Thank you.
Thank you, sir.
Thank you so much for your kind words of introduction, sir. Well, it's my privilege and honor to be here before you. And I'm thankful to the organizers, especially Dr. Om Prakash, Dr. K.N. Mishra, and his strong team. Anyone to name is an apology to others. So they have really had a wonderful host. They have been a wonderful host. And as you are seeing, this IAP PEDICON has crossed its all boundaries. It has gone, you see, to the tune of about 500, as I heard. So you can understand there is no parallel of this PEDICON, and especially the type of hospitality which everybody is enjoying. You see, you have called people, you see, so eminent like Dr. Uday Bodhankar, who has been CIAP president, Dr. Somnath Nimbalkar, and not only that, I mean, each and every one is so much welcome. I think this conference is a great success. My subject today is rickettsial diseases. It is a little bit forgotten in our state, and that's why I have brought this in picture, and I'll tell you why. Well, I hope, yeah. Few of the most coveted re-emerging infections is this, you see. This has been actually being, repeated every now and then. But still, I think we are not that careful about this, knowing fully well that, you see, few of the AES cases in our state, Bihar state, I tell you, have been ascribed to scrub typhus. So it means that we are having rickettsial disease in our state, not so far recognized. And that was my contention to bring notice to your fact that there are, you see, rickettsial disease in our state as well. Napoleon's retreat from Moscow was forced by rickettsial disease breaking out among his troops. And Lenin, during the Russian Revolution, told, it is underlined, that either socialism will defeat the Laos or the Laos will defeat the socialism. It was such a, you see, horror of that time of war. Well, if you see the rickettsial infections, Indian perspective reported from Jammu and Kashmir, Himachal Pradesh, Uttaranchal, Rajasthan, Assam, West Bengal, Maharashtra, Kerala, and Tamil Nadu, and high magnitude of scrub typhus, spotted fever, and Indian tick typhus is present in our country, caused by Rickettsia conuri especially. Of course, scrub typhi is spread by Rickettsia orientia Shushu, but other than that, all the rickettsial diseases are prevalent in our country, especially the Indian tick typhus, scrub typhus definitely. So they are all present in our state. If you see the tick-borne rickettsial diseases, they have severe illness and death despite availability of low-cost and effective antibiotic therapy. This is an irony of the fate, that we are losing few of the children because of not being aware about this disease. Whereas the treatment of this disease is most simple. Nothing like IV antibiotics and this and that. It's very simple, we'll tell you what. But, and when you see, the treatment is so effective that it tells you that the diagnostic test is not really required. It is the treatment itself which leads to immediate resolution of the disease. So that is the kind of thing which we must understand. And knowledge of geographical distribution, evidence of exposure to vector, clinical picture like fever, rash, scar, we will tell you about what it is, headache, and myalgia, along with high index of suspicion, are crucial factors for early diagnosis. Mind you that as in any viral condition, this is in between bacteria and virus, this rickettsia, this is an intracellular, gram-negative, coccobacilli, and this falls between the two. And it's very difficult to grow in the tissue cultures. That's why the investigations they are very, very tough for this disease. But then, as any viral disease presents, it also presents with similar fever, rash, headache, myalgia, you see, like dengue and all. So, you see, this occupies a position, as I told you, between bacteria and viruses, and is a non-flagellate gram-negative pleomorphic coccobacilli, and it is transmitted by lice, fleas, ticks, and mites. Mind you, that these vectors, they are very common in the pets, especially the dogs. These ticks and all, ticks and mites. So, and especially in the herbs, the tall herbs. So, a child playing in those herbs definitely is likely to get this disease. As a cosmopolitan or a city boy with pets. So, neither city or the rural child is immune to this disease. So that's why I told you that this may be around us, but we are not properly recognizing. Invertebrates, including humans, they infect the vascular endothelium and the reticuloendothelial cells. And that is the pathogenesis of this disease per se. We have told you that there are 3 Rickettsia, Orientia, and Ehrlichia family, and these are the genera rather. And I'll just go a little fast about this one, that spotted fever, we have got Indian tick typhus, which is common. In the typhus, we have both epidemic typhus and the endemic typhus common in our country. Scrub typhus is definitely there in those coastal areas which I just told you, turning around to even Assam and West Bengal, then why not Bihar? Miscellaneous, there are ehrlichiosis and anaplasmosis, Ebola and Debonel. Well, if you see the pathogenesis is vasculitis, formation of thrombi, vascular leakage, and sometimes leading on to DIC. Well, non-specific and signs, they mimic any viral illness per se, and it makes the diagnosis more difficult. Incubation period of various rickettsial diseases are between 2 to 21, but more precisely between 6 to 21 days. This is an acute febrile illness accompanied with headache and myalgia, particularly in endemic areas with history of tick exposure or contact with the dogs. Scrub typhus formed the largest group, 62.8%, followed by spotted fever, 32.6%, and then endemic typhus fever, 4.7%. Of course, there's a lot of headache and myalgia. As I told you, there is severe frontal headache, generalized myalgia, especially in muscles of the lumbar region, thigh and calf, mimicking dengue. Headache is noted less frequently in younger children, but often intractable to therapy if it is there. Rash, about rash, you should know that spotted fevers could be spotless too. Mind you that though we are telling a lot about a scar and all, but in 50% of cases only, these rashes are present. So, the spotted fevers can be spotless. Rash usually becomes apparent after 3 to 5 days. Pink blanching, discrete macules, which subsequently become maculopapular, petechial, or hemorrhagic. Occasionally, petechiae enlarge to form ecchymotic patches and sometimes gangrenous patches over this, you see, ear lobes. That's why in few of the languages of Uriya nature, it is called kan papaya disease. So sometimes the gangrenous area is there in the ear lobules. And of course, the scrotum, nose, and limbs may be affected by these gangrenous areas. Distribution of rash is initially near ankles, lower legs, palms, and so on. Palms are affected. We will show you some pictures actually. But before going to those pictures, I think we must mention about this specific scar. Is a necrotic scar is at the inoculating site is seen variable proportion of Indian tick typhus, even a scrub typhus also, and rickettsial pox cases also. This is a black necrotic area, and around which there is some erythematous rim, but it's associated with regional lymphadenopathy, but it's usually non-tender. Well, systemic feature-wise, there are gastrointestinal symptoms, including nausea, vomiting, abdominal pain, and diarrhea. Constipation is seen, particularly in epidemic typhus. Respiratory symptoms being cough and breathlessness. Well, these are the rashes you see. They may be hypopigmented, they may be hyperpigmented, and there may be maculopapular, there may be erythematous, and there may be ecchymotic rashes. So there are a lot, and coming to the typical scar, if it is present, it is a self-diagnostic. You don't have to wait for the result of your investigations. You have to immediately go for the treatment. And to know the scar, you have to go through the hidden areas, especially on the scrotum, in the axilla. So it's the hidden areas where the scars will be present. But mind you, in the setup of that kind of association between those pets and the hubs, I think you must go on to search for this scar. And if it is there, no need of investigation, just go for the treatment. Well, these are a few of the rashes of, purpuric nature, as you see. And now you see the typical kan papaya, which I was just mentioning you, that kankatta ghau. We used to tell in Bihar, we have seen many cases. But I think in those young days, we were not able to diagnose this. We had seen this kankatta ghau. So this kind of thing, if it is there, certainly go for the treatment of rickettsial disease. Don't wait for the investigations. Similarly, this rash, as you see, rashes on the palms and soles, they are very much indicative of rickettsial disease. Usually rashes are there, not there on the palms and soles in most of the diseases. There may be neurological manifestations like dizziness, drowsiness, disorientation, tinnitus, photophobia, delirium, meningismus, and visual disturbances. And mind you, the disease took its name from typhus, which is a clouding of the consciousness. Typhus. Typhoid fever has also been derived from the same, typhus. So typhus is actually a term which refers to this clouding of the consciousness. So there may be, the AES may be presenting as scrub typhus. Life-threatening manifestations could be either respiratory, like interstitial pneumonitis, non-cardiogenic pulmonary edema, neurological, like meningoencephalitis syndrome, renal, acute renal failure is associated with bad prognosis, and DIC, of course, has got a very bad prognosis as well. If you go on to see the sequence of events, you go for this fever with rash, pyrexia unknown origin, fever with edema, dengue-like illness, meningoencephalitis or aseptic meningitis. Always elicit a history of tick bite or ticks on clothes. Sometimes you may have to search that. And playing in areas where there are uncut grasses, weeds, and low bushes. Animal sheds in proximity of homes, contact with the pets, as I told you. Nowadays, everybody is keeping pets. So I think you have to be very careful about that. Travel to forest areas, occurrence with similar simultaneous type of illness, in other family members. And of course, with fever, rash, edema, and scar, as I told you, you should go on to search this scar and treat immediately. Of course, in the investigations, there are few of the pointers. They are not really indicative of that disease per se, but normal or low leukocyte count with marked shift to left, leukocytosis in later stages, thrombocytopenia is also a feature as in dengue, raised ESR and CRP, hyponatremia and hypoalbuminemia with a mild elevated hepatic transaminase. And the DD, viral, bacterial could be meningococcal, protozoal can be malaria, and Kawasaki disease, and so on and so forth. If you go to laboratory findings, no single laboratory finding is specific for early diagnosis. How much time I have? Yes, 10 minutes. Thank you very much. No single laboratory finding is especially specific for this early diagnosis. Of course, as I told you about the total leukocyte count, which is normal to low with marked shift to left. Later in the course of the disease, it shows leukocytosis. Low platelet found in 60% of cases. ESR is usually high. In biochemistry, it is, categorically hyponatremia and hypoalbuminemia, which reflects increasing vascular permeability. Thrombocytopenia, hyponatremia, and normal to low leukocyte count are certain clues to early diagnosis, whereas hepatic transaminase values are frequently elevated. Blood urea may be elevated due to pre-renal mechanisms. Now about serology. Mind you, though the immunofluorescence is the gold standard, but mind you, it is not easily available in each part of our country. And even the Whale Felix test, which was an earlier test, has gone out of date. So you should not depend on these two specific tests, whereas ELISA, IgM ELISA against this disease is quite specific and dependable and easily approachable. So I think the one test you should perform, in my view, in your setup is ELISA for rickettsial fevers. And you should not really hesitate in any case to go on to this test, and I am sure that you will find in your practice in 3 or 4 years, 1 or 2 cases of scrub typhus. So this is very, very important that ELISA, again, IgM ELISA, against this rickettsial fever must be performed rather than the gold standard of immunofluorescence or Whale Felix, age-old Whale Felix. And sometimes PCR has also been advocated, but I'm sure that PCR is also a far cry for all of us. So Whale Felix, it shares the antigens between rickettsia and protease, and this is the basis actually of the heterophil antibody test. The poor sensitivity of Whale Felix is now well demonstrated, so it has gone just out of date. The IFA, the immunofluorescent assay, is the gold standard, as I told you. But mind you, that all serological tests, unfortunately, are positive only after 5 to 7 days, by the time your child becomes more and more critical. So it is your clinical suspicion and sometimes arbitrary treatment which can save the child. This is my preaching to all the practitioners at large. You want to finish? Okay. So once the organizers are around, you are a little fearful that you are being asked to wind up closely. And I'm sure that I have 7 minutes. Thank you very much. So PCR assay, it can be used to detect rickettsial DNA in whole blood. And Buffy coat fraction or tissue specimen, it is the most rapid assay for the diagnosis, but I'm sure that it is not available in most parts of our country. Immunohistochemistry and isolation of the organism also can be performed, but again, it is also a very high up investigations. So in diagnosis, I think I'll summarize again, compatible clinical presentations, tick bite or tick exposure. Just a moment, I'll go back. I'll just go back. If I'm there, yes. Yeah, so tick bite or tick exposure, epidemiological data, suggestive laboratory features, rapid defervescence with appropriate antibiotics. And I think Dr. A.K. Jaswal is here and he will agree with me. We had AS cases due to scrub typhus. Around 24%, you see. Here is the person who will, yes, 24% at one point of time, sir. So, yes, that's right. It was published in the journal, and still people here are not aware of this scrub typhus. That's why I'm re-emphasizing. If you get such clinical presentation, go back to the history, sometimes have an arbitrary treatment with what I'm just going to tell you, outline you. But I think you should think about this disease. That is the point of this, you see, presentation today before you. And there is a rapid defervescence with appropriate antibiotics. This is another proof that it was scrub typhus. The treatment-wise, I think it's very, very simple. Nothing great. Definitive treatment as early as possible to avoid severe disease. Various antibiotics have been used. Mind you, the one and only one is doxycycline, which can be used in any age. You see, irrespective of that 8-year age bar, you can still use this drug for rickettsial diseases because it's a life-threatening and it is so well curative by this and simple 5 to 7 days treatment, that's it. So how it's going to harm a child in 7 days? So that's why doxycycline is the key treatment, I tell you. Nothing more important than that. Rather than chloramphenicol, azithromycin, clarithromycin, roxithromycin, fluoroquinolines, I think they are not going to be compared against this efficacy of the doxycycline. Doxycycline can be given in very many books. You have 2.2 milligram per kg per dose twice. But I think absolutely right that 5 milligram per kg per day in 2 divided doses, that comes to 2.5 per kg per dose. I think 5 milligram per kg per day everybody remembers for most of the diseases, so no problem. And 200 milligram per kg in 2 divided doses for children above 45 kg. Duration of therapy should be 5 to 7 days or 3 days after the defervescence. Clarithromycin, I think I'll go on because there is no time, 3 minutes time left. I may invite few of the questions if you like. I'll just end up my talk with last slide that supportive treatment is of course required in critically ill patients. If you have a cerebral edema, pulmonary edema, you see, the drugs effective for those should always be used. With pre-existing microvascular leakage, you have to take care of the ionotropes. Judicious use of corticosteroids is advocated in this AES or meningoencephalitis. Supportive care is also needed for hypovolemia, coagulopathy, seizures, and intercurrent infections. So, mind you, this is my preaching to all of you that those who cannot remember the past, they are condemned to repeat it. It was a saying by George Santana. Thank you very much indeed for patient hearing. Any questions, please, if you have? I have perhaps 1 or 2 minutes left.
Any question?
Yeah.
Very excellent lecture, sir. Thank you, sir. No question?
Thank you. Thank you.
Thank you so much, sir, as you completed your presentation before time. And it was very useful right now. As we are lagging out of the time, you all know well. So, continuing with the next topic, Dr. Gopal Charan oration. Okay, continuing with the next session, Dr. Gopal Charan oration, community-based rehabilitation, old wine in new bottle. This is our next topic. And to chair this session, I'd like to invite Dr. Shiv Bachchan Singh. At present, he is the director of Shishu Hospital Gaya and president of Bihar. And also Dr. Ashok Kumar, working in pediatrics department of Darbhanga Medical College, Darbhanga, since 28 years, now professor and HOD of pediatrics. And also he is the president of IAP Darbhanga. So let's continue. And now I would like to invite Dr. Uday Bodhankar. Dr. Uday Bodhankar, if you can listen me. And let me again repeat the topic. It is Dr. Gopal Charan oration, community-based rehabilitation, old wine in new bottle. So let's now discuss this topic, and I request everybody's kind attention. And Dr. Uday is here. So let's now continue. And I'd be requesting the chairpersons first to introduce all of us to Dr. Uday Bodhankar. I'll be requesting the chairpersons to please introduce us to Dr. Uday Bodhankar. He's from Nagpur and he is here.
Good afternoon, everybody. I am going to introduce the legend of pediatrics, Dr. Gopal Saran. As I remember, when I joined Patna Medical College in 1972, MBBS course, he was there for a small period and then he retired, I think, or he went to IGIMS, I think. So in brief, I am reading his biography and biodata. The Gopal Saran name needs no introduction. He was famous not only because of his medical profession, but also due to his dedication to our society as a whole. After doing MD from Patna, he did DCH from London, MRCP from Edinburgh, and FRCP. Gopal Saran later on held several prestigious posts and served his estate. He was the senior advisor of ICDS program, Government of India. He served as a head of the Department of Pediatrics, PMCH and NMCH, also the chairperson of the Pediatric Division of Patna. Later on, he was appointed as director of IGIMS. While in UK, he was associated with various prestigious institutes like Preston Royal Infirmary, Department of Medicine and Pediatrics, University of Edinburgh and Sheffield. He took keen interest in research work. Several papers were published in national and international journals. He wrote several topics: child and modern drug for problems in tuberculosis of Indian children, a random clinical observation of acute dehydration in children, hemophilic arthropathy, filariasis and unconsciousness, pyogenic meningitis in children, Henoch-Solin syndrome after insect bite. The last article was selected by Rheumatism Review Committee of Columbia University. It was also abstracted in Dermatology Digest, published from North Illinois. He delivered special lectures on numerous occasions, and his interview was broadcasted by All India Radio. Due to vast experience and knowledge, he was appointed as expert to assist in selection of professors in BHU. He was examiner of MD in pediatrics in various universities across India and member of the advisory board of the Journal of Indian Pediatrics. For the first time, he did successful exchange transfusion in PMCH in 1959 to save a baby suffering from erythroblastoma putalis. He also started oral polio vaccine for the first time in Bihar in 1964. He worked for the anti-cholera campaign in North Bihar, has been visiting faculty University of Hamburg and Münster, West Germany, was in patron-in-chief for Faculty Partner, a youth organization of Patna. This is short in his contribution, but one thing, those who are very senior members in this hall must be knowing him, that there is a complaint, it should be a compliment for him that he was the smartest professor of Patna Medical College. The most smart, handsome professor, Dr. A.K. Pandey sir must be knowing. So I haven't seen such a smart and handsome professor in any medical college till now. So this is in short his introduction. With this, I finish my introduction to him.
Thank you, sir. It's my privilege to introduce Dr. Uday Bodhankar. Actually, he needs no introduction. He is such a legendary figure that every one of us knows about him. He still looks young. So when I asked him, what is the reason, what is the mystery behind this? So I came to know that he was the youngest IAP president of India. That's why today he is young. Next thing, when I knew that he was the first pediatrician from India to be honored by Queen Elizabeth in England. That's why he is young. And third thing I must say that he is the first pediatrician and the rather only pediatrician who was the president of tropical London Tropical Medicine Society. So he deserves so many things. He is the only only IAP president present amongst us. So that is all. In short, his all beauties are there. He is professor. So many of us are professor, but these beauties are not shared by any of us. So I must thank him that he has come to this place to give this beautiful oration, and we all will be privileged by that. Thank you, sir. Please come on the dais. सभी लोग खड़े हो जाएंगे प्लीज इन ऑनर ऑफ डॉक्टर गोपाल सर एंड वी ऑल मस्ट स्टैंड
Thank you, Shaili, for your introduction. And I must admit here, Honorable Dr. Mishra sir, who is the Dean Director of this institute, my chairperson, respected Dr. Ashok Kumar, respected Shivbhushan Singh sir. Of course, in the audience, we see Dr. Bhola Nayak sir. Pranam to you, sir. You are a teacher of teacher. I see Dr. Nigam Narayan, Mrs. Nigam Narayan, madam. Of course, Dr. Nimbalkar sir, and Dr. Alka Singh, Dr. Minoj Singh, and I think Dr. Shah. I think I know everybody of you. So I would like to end up here. I think for you, let me tell you, I came to Patna in 1992. I got the blessing from Dr. Surendra Prasad, who was the first IP patient of India in 1963. With his blessing, I got elected in 1992. So after 32nd बिहार पेडिकॉन है, मैं भी 32nd पेशेंट बन के 32nd हो गया है, 32 साल हो गया नेशनल पेशेंट. तो give big round of applause to Dr. Surendra Prasad and Bihar Pedicon. There, Dr. RKP Sinha, Dr. Thakur, Dr. Jaiswal sir is here. Almost all of them so near to me. Dr. He was there. The book written by Dr. Singh, who was there. So my this thing, Dr. Then I went to Patna, I went to Ranchi, I went to Buddha Gaya, where Dr. Jain sir, Vijay Jain sir, he was supposed to be here. He is like my elder brother, so he was there. So my association with you dates back to 32 years back, 92 to 24. So I was the first national patient at the age of 38, only because of blessings of Surendra Prasad and blessings and greetings from all of you. So, and when I gave this topic to Dr. Mishra, madam, she is here, yeah, Amrita, I gave her 6 topics. She said, sir, I would like to listen from you. Who else can give better than a person like me? For you, I will tell you, I had 15 cardiac arrests. In 2009, I was declared dead. I was on ventilator, deep coma, and out of that I came, and now I'm standing in front of you only because of blessings of God, blessings of all of you, and blessings of my all patients. So that, I think that's why Mishra madam and Dr. Om Prakash ji, they said you have to give topic usually how you can make transforming disability to ability, old wine in new bottle. That is the topic. So I think this topic relates more to me, that I was bedridden, I was declared dead. brain dead, everything. Out of that I came, I was 15 days ventilator, deep coma, with bed sore, everything, whatnot. So 3 months, 6 months I was in hospital. I came up that and now I go to USA, anywhere I go alone with the God and my family. Definitely my family stood behind me, Dr. Nimbakar sir. So my topic was given was the Dr. Gopal Sharan oration, which Dr. Shivbachan Singh sir had definitely narrated. I don't remember whether I met him in Patna, but I definitely met the other person. So my dedication to Dr. Gopal Sharan for his astute clinician, being an academician and being a starter of Patna Medical. We see today all people who are here. I'll bow in front of all teachers. Now coming to my topic, the topic which was given to me was community-based rehabilitation, like transforming disability into ability. Who else can give better than me? I have transformed myself from completely disabled to now able in front of, now 5% limping is there. 95%, you know, when I went to America, I showed my daughter scan because I was afraid that I may develop Parkinsonism. That doctor who was there, he said, I told him, he said, this is a scan of a dead person. So I said, okay. Then I showed him recent scan. He said, yeah, 95% reversal in the brain. And I told him, sir, I was in tears, sir, both the things, I am the person. He saluted, he said, what you, I did meditation, yoga, less of medicine. And I survived all trauma with hypoxic ischemic damage, more than 10 times cardiac arrest. And I think all this goes to my family, parents, and all of you who are here, who prayed for me. Whether Hindu, Muslim, Buddhist, Sikh, all were there. So I salute to all of you for that. So my topic today is transforming disability into ability. Here, to tell you in a nutshell about what is community-based rehabilitation. It was introduced in based on the white joint position paper which was delivered by WHO, UNESCO, and ILO in 2014. Now, coming to CBR, we are going to talk, this topic is slightly dry, I will try to make it very interesting. We are going to deal with emergence of concept of CBR, the meaning of CBR, the major objectives of CBR, the evolution of concept of CBR, and basic principles of CBR, how it can be inclusive, how it can be participatory, how it can be sustainable, how empowerment advocacy can be done by pediatricians like us. So, if looking toward the emergence of concept of CBR, you all know if we give a person a fish, he will eat for a day. But if you teach him how to fish, I think he shall eat for a lifetime. This is the basic principle of CBR, where we involve community, we involve community leader, we involve therapy, psychology, everybody. Now, coming to definition of CBR, I think in the process, it is the definition-wise, CBR or community-based rehabilitation is a systematic approach within general community development, whereby person with disability, PWD, they are enabled to live a fulfilling life within their own community, making maximum use of local resources are used, and not only that, helping the community become aware of its responsibility in ensuring the inclusion of equal participation. PWD stands for person with disability, wherever I use. In the process, PWDs are also made aware of their own role and responsibility as they are the part of community. See, we don't leave PWD as it is. We involve them, we involve community leader, we involve family, and together this forms the community-based rehabilitation. Now, why and where is the need of CBR? You all know in India, more than 70-80% is rural, 30% is urban. So in urban area, you know, disability, there are OTPT schools, there are rehabilitation centers, but no such schools or therapies are available in rural. So CBR need to be implemented where the rehabilitation services are out of reach of the disabled people. This is what is the take-home message. Now, coming to the history of CBR, you will be surprised to know in the early 1980s, CBR was conceptualized, evolved primarily as a service delivery method with a medical focus. In 1994, the joint position paper, which I told you, by WHO, ILO, and UNESCO, which was updated in 2002, further change the focus of CBR from a service delivery approach to a community development process. This is what is the crux of my talk, that instead of being only service delivery, it has got community development underlined it. Now, same thing has been shown in this slide, that CBR brings rehabilitation know-how to villages, which is very important. Urban, you have got in Darbhanga, there will be all facilities, but if you go 50 kilometers from here, you will not have the urban slum and personal facilitated people to take responsibility for their own lives. The process of CBR, as the name implies, has to have its roots in the community and has to derive sustenance and support from the. So all this rehabilitation surrounds the main objective of community-based rehabilitation. Now here in this I have shown what do we see in the picture. You see here, if you take this inclusionness, you take the people with disability in your mainstream, the boat will go fast. But if you silence them, then the boat will be, or the development of disabled will be slow. This is what is shown in this slide. Now, what is CBR team? In short, there are doctors. The team consists of occupational therapists, physiotherapists, rehab nurses, social workers, vocational counselor, psychologists, field workers, and in disabled person with family. This is very important that we don't leave the family out of the reach. Family also is been counseled and has been taught how to give treatment to the disabled person. Now, if you come to the steps in CBR, the steps in CBR will be all these. I will not go. Screening is to be done by the concerned expert. Then early detection and prevention. I will add here, in 1992, when I came to BR, Patna, I delivered the first lecture on early identification and early intervention in disabled child, which was the All India Occupational Therapy Association conference in Patna, BR, where I think the chief guest was the governor of BR that time, Mohsina Kidwai, if I'm not wrong. Kindly excuse me. So awareness development, mobilizing resources and rehab services, active participation through pre-vocational and vocational training, and placement, socialization, all these things will come. Now, coming to CBR approach. So, there are three types of approaches. One is specially workers approach. I think this approach is not much effective. Secondly, generic workers approach. This also approach is not much effective. Thirdly, comprehensive, which is in the end, this is the approach which is more effective, because in this approach, all the members of the rehabilitation team work together. In two approaches, they work independently. That's why we have to concentrate on comprehensive approach in CBR approach. Now coming to the intervention in CBR, it can be home-based, it can be department-based, the department of OT, like you have got Darbhanga Medical College, which is one of the best college, or it can be community-based. So coming to difference between the institution like Darbhanga Medical College and the CBR, community-based, like 50 kilometers Madhubani village, something like that we can say. In institution-based rehabilitation, this is a base limited approach, and at what it can abuse the rights of the disabled children. That's why we do not want to promote, definitely the Darbhanga Medical College should continue, but they should continue outreach program. That is what is the take-home message. Outreach program, and according to whether the needs of the disabled people are similar to what institution. So I think my focus of this talk is, it should be outreach program, community-based, not institution-based. So this is what I want to take home message. With CBR, the focus of control should be with the community, the disabled people, family and community members decide what their priorities are. And they work together with local organizations, local leaders, community leaders will be there, government, institution, in order to access the relevant and appropriate services. Institutions have an important role to play as a reference, like Darbhanga Medical College.